Professor Santosh is the head and consultant child and adolescent psychiatrist at the CIPPRD, which is the Center for Interventional Pediatric Psychopharmacology and Rare Diseases, which is based at the Maudsley Hospital and King's College Hospital in London. And Professor Santosh is also the head of the new Rett Syndrome Clinical Treatment and Research Center, which is the Center for Personalized Medicine in Rett Syndrome, which has been co-funded by Reverse Rett, and it's based in the same location. So Professor Santosh, thank you so much for giving us some of your time today. And please, everybody, can we welcome Professor Santosh in the usual way?
Thank you. Thank you very much. Thank you. So if I were to, let's share the screen, and I'm just hoping that my desktop is, I don't know what I'm sure, what is being seen on the screen. So is the slide being seen on the screen at the moment, or?
Yes, Santosh.
Okay, fine, perfect. Okay, thank you. So what I'm just trying to attempt is to try and inform families in terms of what we know so far. And what I've done is I've summarized some of the survey findings which many of you all have completed. So that will give us an idea as to what's been happening as well. And then I've just got a couple of slides in terms of the AstraZeneca vaccine and the Pfizer-BioNTech, especially in terms of side effects or so-called adverse reactions. And then, so just to let you know as to what is expected, so that, and in terms of where the future lies. So in terms of what have we done during this whole thing, as Federico has been trying to state in terms of how we've managed during COVID, is using technology, using the health tracker platform, using video conferencing, and also sending watches over so that we can actually get data from families, from patients in terms of the biometrics itself, and then trying to, and the psychologists contacting families depending on the need as we find it as well. And so what we've done is, one of the features which was activated in the health tracker was to do with the function which allows for automated risk stratification, and so that we can get an alert if a person completes a questionnaire and there are certain predefined criteria where we are looking at whether it's a risk for COVID or not, and for whether we have to intervene quickly. We then get an alert immediately as soon as you'll complete the questionnaire, if there is something that is going to be worrying that we have to deal with. So what we did was, this is just 2 slides to show you. This is in the clinic, which is not to do with Rett syndrome. This is to do with the CIPPRD, where we see children with all sorts of conditions. The majority of them are autism. And what you can see here is that on the in the bottom, you can see the dates when, roughly in terms of month by month, as to how many of them we got the alerts and what kind of alerts were they. And what you can see is that in terms of physical health alerts, which are in the blue, they've been going up and down depending on the different types of what's been happening outside in the community. But what you can see is that the green one, which is to do with the risk to others, this is when children are getting frustrated and becoming more challenging. There were periods which we can actually tie to the fact that they were not in school and they were spending too much time at home. And then as soon as the schools opened, again, things came down a little bit. So this is to do with what was happening within the CIPPRD. But what we've got is, we've just plotted this in terms of what is happening within the center for Rett patients very specifically. And what you can see is that the 2 things we were monitoring was, which we thought needed to be immediately acted on, was to do with fever and breathlessness. And what you can see is, from April 2020 onwards to February 2021, you can see that the symptoms have tracked almost exactly like what has been happening in the general population. And so there was a peak in September, October, early November, where breathlessness was more in the patients, and also the fever was more. Again, what you have to recognize is this is the kind of thing that could happen on a yearly basis, but this allowed us, as soon as we got the alerts, we were able to contact the families, work with them on what was happening, and that has actually, in my view, kept patients as safe as is possible under the circumstances. So this is just reiterating what we'd already stated previously, and it's on the Reverse Rett website in terms of how we define extremely clinically vulnerable in Rett syndrome. And it's basically those who've had long-term ventilation, those who have significant impairment in the ability to cough or clear away secretions, those who need a device to assist the cough, those who have an unsafe swallow and poor saliva control, and experience frequent choking or aspiration. And if there is any other condition which is not directly related to Rett syndrome, which in itself qualifies for the person to be extremely clinically vulnerable. So this is how we defined it, and we got a consensus from multiple clinicians across the country to do this. And what do we do in terms of to try to reduce risk? Basically, they are at increased risk compared to healthy or neurotypical individuals. And it's difficult to really understand as to how in the early stages they're going to present, because the symptoms of COVID, a lot of them the individuals aren't able to explain to us. So in terms of communicating pain, discomfort, lack of taste, smell, these are things that are going to be difficult. Temperature changes are going to be more difficult simply because their baseline temperature may be different from what you'd expect. And in terms of things about persistent cough, declining oxygen saturation, these are things to look out for. And we'd suggested that a vitamin D supplementation would be reasonable to consider, because there is at least 2 or 3 studies which show that it reduces the risk of complications. And vitamin D, especially in individuals with Rett syndrome, where there is a prevalence of low vitamin D levels, we thought it was a reasonable thing to consider in terms of treatment. So I'm now going on to the survey that we've done, and this is what we've got is data from 44 parents who completed it during the first part of the lockdown, and 24 parents who've completed it more recently. And this is just in the last column is 25 individuals who've completed it from the general clinic that I run, just in terms of comparing what kind of problems individuals are having. So if we take the first one in terms of designated as a extremely vulnerable individual, we have 15 individuals out of 44 being classified as that, getting a letter, and 10 in the second wave informed to us. But none of the rest in the clinic, having actually achieved it, got a letter from the government as such. So when you look at what is the person currently doing because of the underlying illness, what is happening is that when it comes to continuing life without any change, I was surprised, but there appears to be a few individuals who report that their life continues as if nothing has really changed. But the majority of them have, they're in terms of social distancing, self-isolation, they're having to do that. When it comes to being exposed to someone else with COVID symptoms, you can see that there's a total of 8 individuals who've been exposed during this period. What was interesting was that how many of them were living with someone else who had high risk for COVID. And you can see there was, 5 to 7 individuals where parents themselves have underlying health problems as such. So this is something that has to be taken into account, that it's not only about the child being at risk, but actually there may be others in the home itself who are at high risk. And then in terms of parents or carers having been able to arrange modifications, we had 21 individuals saying that they had been able to do it. And then household members working as key workers, there were 13 of the 44 who were working as key workers. Now, the other part of it was that in terms of family members, whether anyone had, fallen ill physically, we had to self-quarantine, self-quarantine without symptoms, lost job, reduced ability to earn money. And so you can see it's a small number, but, 1 to 2 individuals have had this happen to them. And in terms of financial difficulties or financial changes, probably, what we've gathered is around 47 individuals have had that of the ones who've completed the questionnaires. And in the first lockdown, you can see that 39 of the 44 were living at home. Carers in residential setting, only 4 or 5 of them. And then what you can see is that families been following guidelines for shielding. Most of them were able to follow. Some of them were finding it difficult because they didn't consider the person vulnerable because they were already taking care of everything that was needed, and not following guidance because it was too difficult. There was one family where it was happening as such. But this is interesting because the number of families reporting that they stopped carers coming home in the first lockdown, you can see the majority of them have actually either cancelled, carers coming home or cancelled respite outside. In the second lockdown, it's slightly less, but again, the numbers are smaller. This is interesting because this is a small number of individuals who are actually being managed in a care home or a residential setting. And in that, 3 of them families claimed that they had been prevented from seeing the person. 4 of them were supported in terms of communicating with or visiting the person digitally. And then 6 and 4 informed us that the advance statement have been made about whether the person should remain at home or go to the hospital if they became infected. So this gives you an idea as to how the families, all of y'all actually went into action mode to try and plan ahead. And I think it's what would have been expected. Now, here there are some aspects of it, and this is about social distancing, being able to follow guidelines of social distancing. One family said that they couldn't follow it at all. Similarly, in terms of hand washing directives, one said no, and coughing, the etiquette was most of them were able to follow. There was, in terms of adherence to social and self-isolation, when infected, 3 of them reported that they couldn't or were not. And again, when it comes to shielding, the 6 families reported and they were not. So this shows that there is, amongst the people we're dealing with, there are differences in terms of attitudes in some instances. However, the most important thing is that when you're accessing support and we are able to respond quickly, we have been able to keep people safe, generally speaking. Now, this is the second part of the survey where it was specifically looking at parental mental health and impact of COVID and lockdown. And in the first thing, what we can see is that anxiety is quite significantly high, because almost 50 to 60% of the individuals, parents, were demonstrating that they had some anxiety as such. In the second, similar proportions. And when you look at it, it's not that, probably slightly more than what is being experienced by the other children in the clinic. So this is to do with parental anxiety, and this is something that the psychologists in the team have been working with families to try and help as much as is possible. This is about depression. And again, these are just items, and I'm not saying that this leads to depression per se, but what you can see is there are symptoms like feeling emotionally exhausted, lacking motivation to do anything, fatigued, becoming irritable, and so on as such. And then again, when it comes to it, there are, in terms of having thoughts of self-harm, there's a small minority who've ended up experiencing those thoughts too and feeling pessimistic about the future. And then it is about having periods of, the parents reporting that they're finding it difficult to concentrate, indecisive, slightly overactive, and so on. But and investing free time reading or watching, spending more and more time looking at COVID-related information. But the thing is that there are some individuals who are finding it difficult to take care of themselves, manage household chores, and these are not different from what is happening in the general population. But what this means is that by having this information, we are able to, as a team, contact the right individuals to see whether we can actually provide any support that is needed. So now going on to a very small section in terms of the two vaccines, which I mentioned. One is about AstraZeneca vaccine, and this is basically a recombinant replication deficient chimpanzee adenovector virus vector. And what it does is that it's genetically modified. It cannot replicate, but what it does is that it contains the spike glycoprotein, so that therefore when it gets into the body recognizes it, and then it mounts an attack against it. And that's how we, if the true COVID virus were to attack the body will already be prepared to be able to attack it. So in the AstraZeneca vaccine, it's being tested in 18 and over year olds, and the studies have excluded patients with anaphylaxis and angioedema, severe renal failure, things like that, and immunosuppression. In the pediatric population, the safety has not been established as yet, and a new clinical trial for 6 to 17-year-olds has started. So we will get the data probably in around a few months, and when we do, that will then be the basis on which one can actually make a decision about whether it is appropriate to use it in children under 18. Now, looking at the adverse events with vaccines, I thought that it would be useful for us to have this discussion frankly, because this is the one thing that people in our clinic, we've had this discussion around, are people getting unusual side effects? Is the patients getting side effects if they're given the vaccine, and so on? And so what is considered to be very common is anything which is less than, if it's occurring in more than 1 in 10 individuals, then it's very common. If it is between 1 in 10 and 1 in 100, it's considered common. Uncommon is 100 to 1,000, and so on and so forth. And what I want to highlight is this is the findings from the adverse events reactions to vaccine, the AstraZeneca one. And what I need you to just look at is very common is you have the tenderness in the site of the injection, fatigue, headache, malaise, myalgia, feverishness, chills, arthralgia, nausea, and so on. All of this is very common. So which very common means anything that happens more than 1 in 10 individuals experiencing it. And so this is a very common phenomenon. And then you have other things which are there, diarrhea, vomiting, which is common, which means that it's less than 1 in 10. And then you have some other things which are uncommon, which is more like 1 in 1,000. And it's very rare when it comes to anaphylaxis. But what is really important to remember is these symptoms are usually mild to moderate, if at all. They don't usually last for more than a couple of days. So by day 7, only 4% have have around one of these symptoms present. And what in the AstraZeneca data, what it shows is that the adverse reactions after the second dose were milder or less frequent than the first dose. So this is something that is very specifically available for this vaccine that we know. Next is just the similar information about the Pfizer-BioNTech vaccine. And here, what I wanted to show was, because it just gives you an idea, there is nothing which is different about the two vaccines in terms of adverse reactions. They're exactly the same. Just the pain and the site of the injection seems to be slightly more with this. Fatigue, headache, myalgia, feverishness, chills, arthralgia, and so on. And there's been just one very, very rare presentation of acute peripheral facial paralysis, which is temporary. But apart from that, the side effects are no different. The adverse reactions are no different in the two vaccines. The mechanism of action of this particular vaccine is it's a messenger nucleoside modified messenger RNA, which is a new method of producing vaccines. As such, it's the first time. So this is, it's a game changer in terms of vaccines itself, because the methodology has not been tried before, and it has been successful. So it's very likely that this methodology will be used for other vaccines too. And it is actually injected it's formulated in lipid nanoparticles, and it's through that the virus actually, the mRNA can get is injected into the body. And what it does is that it elicits exactly like the other vaccine. It elicits antibody reactions as well as cellular responses, which is aimed at the spike protein. As such, in terms of the pediatric population, the Pfizer vaccine has been trialed in 16 and over as opposed to 18 and over. And the thing is that, as with everything, the no vaccine is perfect, and it may not protect everyone. And the data on this shows that we don't know whether we can actually combine vaccines and whether it will have the same effect. So you take Pfizer once, and the second time you take AstraZeneca, or vice versa, or something else. But there is a trial ongoing at the moment looking at mixing and matching to see whether that increases the immune response or not. This is very specific to both vaccines in terms of when it comes to thrombocytopenia and coagulation disorders. So if someone is taking blood thinners, if you have an injection, you could end up having, because it doesn't stop bleeding, you can end up having a hematoma, you can end up having a swelling there, more usually there. So that is to do with both vaccines, even though I've mentioned here the AstraZeneca, it's exactly the same even in the Pfizer one. In immunocompromised individuals, it has not been known whether individuals with impaired immune responsiveness can actually generate the same level of immune response as others if you're taking an immunosuppressant. So that is something that is being looked at, and especially when it comes to children, because of the immune response being slightly different, then you may end up having to repeat it properly there. So interchangeability, it's the same thing. And I've mentioned this already, that there's a new trial going on. And of course, as of 8th of March, as you know, out-of-school settings and wraparound childcare providers can now offer both indoor and outdoor face-to-face provision to vulnerable children, young people under any circumstance. And basically, all of the children, the provision is it's available on the website in the government thing as such. But the main thing is that since 8th of March, out of school settings and wraparound childcare can be utilized as such. Now, how can you, and from the 29th of March, what is being expected is it's going to be expanded further, and so that it can, in terms of access to lots of other things, including respite and so on, can be done better. How can we, reduce the risk? How can we minimize the risk when children are accessing school? Sending them to a provider that has COVID protective measures in place, limiting the number of settings that the person attends, so that it's not going multiple settings at the same time. Working with providers to ensure the child is grouped with children with that's in the bubble. Taking practical steps to reduce the risk of the child coming in close contact with someone who has the virus. And then, of course, discouraging a child from mixing with different peer groups outside of the specific activity of the group setting. This may not be, as relevant or as thing in Rett syndrome, because usually you end up having someone working with them at all time. And then this is the last slide to just say that in terms of children with health concerns, few children are clinically extremely vulnerable, needing shielding. Even in our group, you can see around roughly 40 to 50% have been classified as such. Children deemed clinically extremely vulnerable are advised not to attend out of school settings, while shielding advice applies nationally. So once the advice changes, things will change as well. And of course, when it comes to children and young people whose parents or carers are clinically extremely vulnerable, can continue to go to out of school settings if they're eligible to do that. And in terms of significant risk factors are concerned, you have to discuss it with the doctors concerned, or the provider as such, and the school itself. And parents and carers should continue to look at holiday clubs, out of school settings, and offer respite childcare if the national guidelines allow it to change. And this is different in different settings. Sometimes we've had changes according to the region. Sometimes it's to do with whether it's in Scotland, Wales, and England. I focused on a broad thing of what could be considered as how one views looking towards managing families. So thank you. So that is my presentation. I'm very happy to answer questions and clarify things. So I'll just stop sharing so that. So hopefully the screen stopped sharing. So I'm more than happy to clarify, answer questions, anything.
Great. Thank you, Professor Santosh. That was really interesting, and I'm sure I speak for everyone when I say that's very valuable information for all of us. We have had a few questions that have been sent in before today. A couple of them I know have come from parents who have then not been able to attend for various reasons, so they'll be very interested to see the recording. And we've had a couple on the chat room. So if I tell you some of the ones that have come in advance. So a question, how long do you think it will be before we have the evidence to safely vaccinate young children? So, 5 and upwards.
I think it's going to take some time because they're going to be waiting for the data before they decide. Because of the fact that there is no data available as such. There are 2 trials going on. So, in the US at the moment. So I think we would be in a position to have some data when they achieve the numbers that they need to in terms of being able to interpret the results as such. So the main thing about children is whether they elicit the same kind of immune response as as the adult. And theoretically speaking, they should, because in the elderly, we were worried whether the vaccines would be able to elicit the response. And now we know that even in over 80s, the 80-year-olds, it is eliciting the right response or as such. So, but it has to be proven first before it can be decided. So I would suggest that it would take at least a few months, unfortunately. There is no shortcut to it, because the one thing you don't want to do is use it if without evidence as such. So that's the thing. And just before I go to the answer the next question, I just wanted to highlight one thing which I had forgotten to mention in the thing, because the slide, I tried to reduce the slides for this time as such. And that is that there are a couple of individuals who stated that their children's seizure frequency had temporarily gone up during the period of the post-vaccine, once their children had been vaccinated. And that is usually arising because when you have increased temperature or changes in temperature, seizure thresholds can change as well. So that is just a temporary phenomenon, which is what has been reported in our own clinic, which I didn't have time to gather all the data, which is to put into a slide. We have interviewed at least 30 families from the CPMRS itself, and we've looked at both the immune response, the vaccine response, whether there was an adverse event in the children themselves, as well if they had been vaccinated. That's usually the young adults, and also the family members who had taken the vaccine. And the reason I wanted those two tables to be shown, both in terms of the Pfizer vaccine's adverse effects as well as the AstraZeneca, is that it is very, very common, and what has happened in the families is no different whatsoever. There's not a single side effect adverse event reported from any of the families from carers or from the patients themselves, which is anything different from what you'd expect from taking from an ordinary person without any condition taking the vaccine. And so that is the only thing is that a couple of patients have mentioned, the families have mentioned that the seizure frequency increased temporarily, and then it came back once the fever was, got better. So that is what would be happening if someone had fever from an unrelated cause. If many individuals who have epilepsy, which is not fully controlled, when you have high temperatures, you will end up with slight increases in frequency. So that is about the only thing. And so I just wanted to clarify that so that I didn't forget it as part of the discussion.
Thank you. I know that Becky's posted a question about that. Does that kind of clarify for you, Becky? Great. A follow-up question from the same parent about the safely vaccinating young children is slightly more personal, I suppose. Would you personally be willing to prescribe the COVID vaccine to younger children off-label once that evidence is in place?
The issue is not about prescribing, it's about getting access. The COVID vaccines will be provided to specific outlets. Like the GP is going to be the most likely person in terms of discussing the pros and cons and recommending to the GP to be able to do that we wouldn't have a problem. We would be able to, once we've got some things that evidence that it's not doing much harm, we would be in a position to write letters, which we've already been doing, in terms of the how we've been looking at the different families. So, for example, some of them GPs have said they're not classified as being extremely vulnerable, so therefore you'll have to wait your turn kind of scenario, even if you're in your 20s. And we have sent letters to state that they may not have got a letter about shielding, but actually they are at high risk, and so that has actually enabled them to get the vaccine. And similarly, we've also assisted family members who, one family member, parent may have got access to the vaccine because they're registered as a carer, the other is not, and we have written letters of support which has assisted the second person to get access to the vaccine. So we have, as a center, been doing it automatically to try and support families and carers about it.
Okay. That's great, thank you. A question that I think quite a few people have put forward is, has anyone, to your knowledge, in the international Rett community been hospitalized with COVID?
Fortunately, no. I haven't, someone who's ended up needing to go into intensive care or anything like that, no. If the question was to do it in my clinic, in the non-Rett population, I have had a couple of patients who ended up being hospitalized, and they have recovered, but they have not needed, they have not needed intensive care, but they have needed to be in hospital, but for various reasons. But we have managed to keep most patients with symptoms, even if they're tested positive, out of hospital.
Okay, that's great news. Very good news. also a similar line, is there any evidence that children with Rett syndrome will be more adversely affected by COVID?
The thing is that if this question was asked of me before this information of a whole year, my prediction would have been that there's a whole lot more individuals would have been hospitalized. And luckily that has not been the case. And that's why I was just putting the figures of the non-Rett patients in my clinic who would have similar kind of vulnerability in other ways. And actually it doesn't seem to be very different. And I can see that Becky's written about one child having died in the US, and it is it's possible. But the thing is that we have to take it into account as to what is it that you're comparing it against. And that is the issue. And as I said, this is something that I would not have predicted. I would have thought that they were going to be far more vulnerable because they have pre-existing cardiorespiratory problems, and they are frail, and they are wheelchair bound, and many of the time, and and they're in contact with multiple carers in multiple settings. So if it is to do with respite, carers coming in, all of the high risk, sort of factors. But luckily, it has not turned out to be the case. So I think we should continue to do what is being done, because it has been effective to keep people safe.
Yeah. Okay, thank you. I mean, I think a lot of these are based around the same kind of idea. Would a COVID infection affect a child or adult with Rett syndrome? Would it affect their heart specifically?
Okay, I mean, if someone is, being COVID positive as a test is very different from actually getting multiple systems being involved in COVID. So if someone were to get COVID and actually multiple systems get involved, the heart can also be involved because you can get myocarditis as such, because it's an inflammatory process, and it can affect the kidneys, it can affect the heart, it can affect the breathing in terms of the respiratory system, it can affect the brain. So there is, it can affect any system in the body, but it depends on whether the virus has actually got to those, to the organ concerned, and what the reaction of the individual is about that. And again, it's what you learn. And because the title was "What Do We Know Now?" I thought that I'd put it in context of what we've learned from the center. Because the center has got now around 120 patients, and so it's not a small number. 120 patients in the UK, coming from all over, and with different levels of risk and ability to manage different things and so on. And if despite that we haven't really, and I'm not saying that something may not have happened which we are not aware of, but at least the ones whom we are aware of, and we have gone through in detail when someone has had symptoms. And because this is the same thing we're doing for the non-Rett individuals in our clinic. And so what is striking is that doesn't seem to be very much difference between the two groups in terms of what is happening. And the only difference is that the non-Rett group, the families have not yet got access to vaccines very much, and they're only starting to, because of the new guidelines about things as such. So that's only starting in the other group, but in this group, it seems to be, in the Rett population, it seems to have been better managed.
Okay. A follow-up to that as well. If somebody with Rett syndrome has had COVID, are there any particular checkups or follow-ups you would advise in the kind of weeks and months afterwards, specifically to monitor that person?
Yeah, I think it's not just Rett syndrome. I think anyone who's had COVID, it would be good to keep track and see whether there is any kind of any symptoms that are occurring which were not there before. And in Rett syndrome specifically, we personally, I would, it's not with evidence because we don't have an evidence base, but what I would do is that look at the autonomic and the cardiorespiratory problems more carefully and monitor it. Because one of the outcomes from COVID in non-Rett populations is autonomic dysregulation as a complication. So there is a significant group now being targeted, and it's called POTS, where it's postural sort of changes in in terms of your heart rate, and you can actually feel things and so on. And it's now being raised as a possible outcome from COVID. So because of that, because in Rett syndrome you already have inherent autonomic dysregulation, I think if someone does get it, we need to be more. And this is just my personal view, because this is not based on evidence, and I need to make it very, very clear because we don't have that. But as a clinician, I would want to look out for those systems a little bit more and monitor them more closely.
Okay, yeah. Okay, a couple of more general questions, I suppose, about the vaccine, which there's been some discussion around. Should doctors be giving the vaccine to people who have already had COVID? Why is there concern around this?
Okay, the thing is that in terms of the Pfizer vaccine, I think it was what they found was that there were more adverse reactions in those individuals who had already had COVID previously. But that is that's why for any vaccination you're being asked whether you had COVID or you had symptoms of COVID, and you're not given the vaccine for 4 weeks after, which is basically having had COVID recently. The virus has done what the vaccine is doing. So it is. So if you give it, you had it last week, and then you had COVID last week, and then you give the vaccine today, then you'd be getting a double whammy of the impact. But on the other hand, if it was given after 4 weeks, then all that it would do is be more like a second dose of a vaccine. So that's all that it would be eliciting. So it is not that it is contraindicated. It's not that it is thing. It's just you have to inform the vaccinator about it, and the timing will have to be decided.
Okay, and in that scenario, if you did happen to have the vaccine very recently, or say you had COVID but weren't aware that you had it and had a vaccine as well, is that in any way dangerous or a problem, or just not needed?
It's the issue is that having had COVID in the past does not mean that you don't need to be vaccinated. It is very likely that the vaccination is going to be an ongoing process for us for a few years, where it's going to be more like the flu vaccine, where we're going to have to take it at regular intervals. So, so I don't see that as being a big issue. But on the other hand, if something happens, you have to inform, and the doctors will do what is needed to be done. But it's mainly to do with the serious reactions are immunological. Do you have anaphylaxis? That happens within 15 to 20 minutes at best. So that's why they don't allow you to leave the place for 15 minutes at least when you get a vaccine. So that is extremely rare, and it's not something that often would happen. On the other hand, those who had a past history of anaphylaxis or are carrying an EpiPen, then those individuals, it would be wise to inform and get it done within the context of a hospital setting. Just if you have an anaphylactic shock, then you're in a hospital to be able to do it, rather than in a community center where you may not have access to that. But that is very specifically to do with those individuals who are carrying EpiPens because of already having had a previous episode of anaphylaxis.
Absolutely. Okay, thank you. I think that's all the questions that we've had sent in, and all the ones that have appeared during your presentation. So does anyone have a question that they would like to ask directly at this point? Or anyone have a question that has been asked, but they feel they haven't felt they've fully answered, or they still got a follow-up question?
Yes, Rach.
How did you know I would have a question? So I was just thinking that how helpful it is to see with all of the data, information about the control group from CIPPRD as well. And I had two questions, which I'll ask separately because I think otherwise we'll get confused. So can you explain how it helps to have that control group? I think it was kind of obvious actually during this presentation how it's helpful, but I think sometimes people think, oh, why have you put in information about people with autism on the side here? So could you just elaborate a little bit on that so that we can...
No problem at all. Yeah, no problem. The reason why we need to have some sort of a control group is because we shouldn't assume that whatever we see in one group is arising from because the person has got Rett syndrome. So in this particular example, we've got various issues around anxiety in parents in terms of ability to manage lockdown, in terms of financial consequences. There are lots of different things which are there. But if we didn't have something to look at and see, so these are broadly speaking, they're not perfectly matched, but they're broadly speaking seeking help from the same center because they're really, really difficult, they're complex and so on. And when you look at that, and if you see that there aren't very many differences between what has been reported in the two groups, then what the take-home message would be that yes, in Rett syndrome, there is high risk. That shouldn't be underplayed. But on the other hand, we also need to recognize that for whatever reason, and it may be that there are very different reasons why the two groups end up with similar numbers. So for example, it could be that Rett families are already coping with managing difficult scenarios from very early on. And so therefore they are much more equipped to deal with something like lockdown compared to someone else. But on the other hand, as time goes on and things start becoming more and more difficult, you start realizing that actually you need that space where when you said no to carers before, there's only that much that you can actually get thing. And so therefore you end up saying, okay, they can go to school, they can do this, I can let carers in, I will take this extra level of care to be able to do that. Well, on the other hand, in the other group, they've not even had the option of having carers coming in because they've not been given carers. But for them, it is the ability of not having the child out of the home because that was what their respite was. And so it may be different reasons why it is happening, but actually you end up realizing that the findings are quite similar, and it is not to be underplayed. So for me, the take-home message from this is that parents, whilst they're putting on a very stoic front, doing very well and everything, if you look at the numbers, actually 50% of them are finding it stressful. And it is coming at a cost to them, personal cost, as opposed to, whilst they may be doing everything for the child perfectly well, but it's coming at a cost for themselves. And that is something that as a team, we are hoping to try and see whether we can develop some group interventions for that, so that we can actually get families to come together and we can actually do it virtually, so that to try and improve that, sort of self-well-being aspects of it, because I think it's coming at a cost to them. So that's one of the things that I did want to highlight, and that's part of the reason why I showed the slides with the data like that as well.
That's really helpful, thank you. And just considering what you've just been saying about how Rett parents' emotional responses compare to the other group, what I was wondering was, before COVID, did you take data on anxiety levels of Rett parents, and how does the anxiety level in COVID compare to before? I mean, are we just higher? Do we have a higher level of anxiety than other parents of?
No, in fact, if anything, the the only study that has looked at Rett families, ASD families, and other families. It shows that Rett families are probably far more resilient than the other families. And that was just only one study that I'm aware of in the past. But we have some data on the parental burden in the thing. We haven't really looked at the data in that sense because I wanted to present the COVID data at this point in time as such. And the more, and the plea here is that for anyone attending the thing, we would really appreciate it if you were able to complete questionnaires online on the health tracker at regular intervals, because it actually is data that drives science. If we don't have data, then we would, it's like if I hadn't shown that data screen of how the COVID vaccine and the thing, Pfizer vaccine, the adverse events, and this is published on the government website, but very rarely do we read it and put it together so that you can actually compare side by side. And so, as has been raised in the chat, most people assume that the AstraZeneca one has got more side effects. But actually, when you look at the numbers in thousands of individuals, and this has been updated in the last month, you can see that actually they are not that different in terms of the adverse reactions as such. So it's just a question of thing. And of course, we will learn. There are things about blood thinning and clotting and all sorts of things that are being debated about. We will learn, but at the moment, as things stand, I think the data out there suggests that either vaccine is good. Either vaccine, no vaccine is without adverse reactions. These are expected reactions, and they are occurring in 50% of the people. So it is not that it is to do with, so if a person with Rett syndrome is given the vaccine and that person ends up with fever, it is not unusual. It is what is happening even in the general population. But the one thing which has been raised here in the chat as well is that when you have raised temperatures, it can have other consequences, which is not directly related to it may or may not be directly related to the vaccine, which is to do with the fact that when you've got brittle control of seizures, one of the things that we know is that when you've got fever from any cause, your seizure control can change temporarily. And when it gets down, then it comes back to what it is before. But these are all things that we have to learn, and I'm hoping that the information, as we get more information from the group, we will be in a much better position to, the more data we have, the more convincing we can be with our outputs, and the more likely it will be accepted for publication in scientific journals. Because if we have just 44 completions and then we don't have enough to be able to think, and we say, okay, we've got 120 on the system, families in the system, the more information we get, the more we are able to say that what we found is actually what it is.
Well, I think that when the information is coming back to families like it is today, that's when you can really see the value of being involved and participating in the research. I mean, it literally isn't just, giving your information up and then that's the end of it. It's coming back to it in a productive way and also benefiting the wider Rett community.
Absolutely.
So I think that that's part of the message of what we've heard today, really, and hopefully we can continue to pass that message on. So, Professor Santosh, as always, I'm amazed by the work that you've been doing with families, you and Federico and Roxana and Tilly and everyone on the team.
Yeah.
And also, with the work that you're doing, tracking what's going on for people during COVID, which I think is really important. And thank you for taking the time to present to us today. And thank you to everybody who's joined for all the questions and for listening. If you've enjoyed today's session, we'd like to encourage you to take part in next week's session, which is with Professor Santosh's colleagues, Tilly and Roxana from the CPMRS. And Roxana is a psychologist, and they will be talking about coping strategies and resilience for families during this situation, which, even though we're seeing some light at the end of the tunnel now, I'm sure everyone will agree that it's still there's still challenges as we move into the summer, even if it's just the concerns about what's going to happen next and will we see any further surges. So anything we can do to build our resilience and feelings of well-being, I think, is important. And also after this session, Beth will be sending out a survey, which hopefully will only take a minute to complete, and this will help us to plan future sessions and to obtain more funding for this project. So if you can do that, we appreciate it. So thank you very much, Professor Santosh, and to everyone for being such a great audience, and hopefully we'll see you again.
No problem. Thank you.
Bye.
Thank you, everyone. Take care and keep safe.
Bye.
Thank you.
Thank you.